Hello, this is Lee Schilling, an OBGYN physician, back with another session on contraception. This one is going to be on birth control pills or steroidal hormonal contraception. Steroid contraception, and steroid is just the chemical name for estrogens and progesterone and many other things. Early in the 1900s, hormones, which estrogen and progesterone are, were first seen as linked to fertility. In the 1920s, hormones were used in rabbits to control fertility. And then 10 years later, in 1931, Dr. Ludwig Haberlandt proposed hormones for birth control in humans. And he's known as the father of hormonal contraception. Prior to the 1940s, the only steroid sources were animals, their urine or their organs. And to make a birth control pill, you're going to need like 35 micrograms of estrogen and up to a milligram of progesterone. But in order to get much in terms of the steroids, you'd need 80,000 sow ovaries. They'd only give you 12 milligrams of ethinyl estradiol, and you'd need 2,500 pregnant sow ovaries to get 1 milligram of progesterone. Well, that's not very practical, is it? So to provide today's low-dose pill dosages for one person for 1 year would require 9.56 milligrams of ethinyl estradiol and 273 milligrams of progestin, which is the term we use for progesterone in these, or progesterone-like things in these conversations, and which would need to get that much estrogen and progestin. For the estrogen, you need 63,700 sow ovaries, and for the progesterone, you need 687 and 500 pregnant sow ovaries. So in the early 1940s, the pill was still a pipe dream. It really wasn't until the 1940s when Russell Marker, who's a chemist, discovered and found out that from the Mexican sweet potato, you could get all the chemical he would need to come up with an estrogen and a progestin. And this was a real breakthrough. I mean, sows cost a lot more than a sweet potato. So he continued work. Now, estrogens look like this, in case there are any chemists in the audience. And they have an arrow pointing down to the 3 lines, and that just is called an ethinyl group. And what it does is to prolong how long the medicine stays in your body. And that determines how often you have to take it. So the estrogens can't be used by themselves. You need to give them along with the progestin or the progesterone-like thing. And in order to do that, you you have to come up with the progesterone-like substance. And Carl Gerisi at Stanford first developed the progestin in the 1950s. And you can see the chemical formulas there. And the one on the top left has a label C19 and an arrow pointing to it. And the reason that's the case is because if you leave it in there, then there might be some male things like whiskers, and you don't want that to happen. So you can remove that and it won't happen. So in the 50s, things were really getting pretty well together. They found a good source for providing these hormones. And the next step is the development of the pill. Well, that was initially commissioned by Margaret Sanger and her heiress friend, Catherine McCormick. Margaret Sanger was always interested in contraception, which couldn't talk about back when she first started her clinic in 1916. She was put in jail for talking about contraception. And I'm sure happy that's not the case today. So in the early 1950s, Gregory Pincus and Harvard Med School gynecologist John Rock began work on a birth control pill, which was FDA approved by May 9th, 1960. Well, how do contraceptive steroids work? They do a lot of things. The progestins thicken the cervical mucus, and that's a good thing if you're trying to make it hard to have a pregnancy, because sperm have to swim up through the mucus that the cervix manufactures, and if it's real thin and stretchy, they can do that very easily. If it's thick, they can't. And what else do the progestins do? They decrease the estrogen receptors. And estrogen receptors help, when they are stimulated by estrogen, they help glands that help support a pregnancy grow. So it says here it produces atrophic. That means not much growth of endometrium. What's that going to do to your periods? They'll be lighter. Won't be as heavy as they used to be. And that's normal. What else do the progestins do? They suppress the mid-cycle surge of LH. And that suppresses ovulation. That's critically important. Now, what do the estrogens do? They provide stability to the endometrium so you don't have surprise bleeding. They also suppress FSH, which is critical. That's the follicle stimulating hormone from the brain. And if you suppress it, that keeps an egg from being developed during that part of the cycle. And it also makes the progestin agents work even better, and it increases the concentration of the progestin receptors in the lining. So how do contraceptives work? By preventing ovulation. If you don't have an egg, you're not going to have a pregnancy. So when did the first pill come out? This is the bottle it came in, and it's called a Novid, and it came out in May 1960. The FDA approved the pill. When the pill first came out, there was a lot of discussion and a lot of controversy. A lot of people thought, well, we shouldn't have pills, that's unnatural. And so you would hear all kinds of things about how bad the pill was. And one thing was people were told if you've never been pregnant and you take just one birth control pill, you'll have a 10 to 15% chance you'll never be able to get pregnant. And guess what? That's true. Well, it has nothing to do with contraceptives. So don't let others tell you you shouldn't take it because I took the pill and now I can't get pregnant. That may be true, but it's not cause and effect. And that's very important to understand. Also, 9% of men between 15 and 44, 10% of women in the same age group are infertile. That means they can't get pregnant. And it's about the same in men and women. And 30% of infertility cases can be attributed only to the female, 30 to the male, and 30 to a combination of both male and female. And then 10% of cases have an unknown cause. And now they're discovering that the uterus itself may not be able to support a pregnancy. And there have been globally about 100 cases of people who have successfully had a uterine transplant. And they're working on that more and more all over the world. Well, the way these work is to get a blood level. And then when you have that, it'll do all the things that we talked about a few slides back. And there are many ways to do that. You can do it by swallowing a pill or getting an injection or a trans anything. I mean, putting a patch on the skin or contraceptive steroid in the vagina. And as long as it will transfer the steroid to the blood level you need, it's going to work. And creativity is now the limiting factor to how to do that. What applies to the pill also usually applies to the other ways to get a blood level. So we'll talk a little bit about the normal cycle. And what we're talking about is the menstrual cycle, and that's sort of defined as being from the first day of a period to the next time you have a period. And that's usually, for many people, 28 days. In the middle of the cycle, which would be day 14, is the time for ovulation, when the egg is released. That's the time that you can get pregnant. Now, some people ovulate as early as day 8 and some as late as day 19. And everybody doesn't have the same cycle, but it doesn't mean that there's something wrong if you have your ovulation earlier or later. Now, the normal cervical mucus changes indicate what part of the cycle you're in. And what you can see here is the upper left picture shows the cervix, that's a speculum inserted in the vagina so that you can see up at the very top is where the uterus sort of pokes out. Uterus is about the size and shape of a pear, and what we're seeing here is the small end of the pear. It's called the cervix of the uterus. And normally that opening in the center is closed, but at mid-cycle it dilates. And you can see that the arrow is pointing to where the cervix is, and it shows that it's dilated. And the kind of mucus that the cervix produces is very, very stretchy and doesn't have any cells in it, so it's rather pretty and clear. After you ovulate, that changes, and at the bottom left you can see like a little Q-tip pressing on the cervical mucus, and it's very thick looking and not at all stretchy. And as I think I earlier stated, that's going to keep sperm from swimming through very easily. And the type of mucus above, where it's very stretchy and clear, doesn't have any cells in it, sperm easily swim through that to get out to the tube and fertilize an egg. Failure rates first year of steroid use. Well, depending on the method, it's going to determine what the outcome is, and it's different for the various different steroids. But for those people using an implant, the lowest you could expect is the same as the typical. In this case, 5 per 10,000. If nothing is used, the lowest expected and the typical are the same. It's not 100%, it's 85%. And the reason for that is that there's a 10 to 15% incidence of infertility. Well, what kind of OCs or oral contraceptives and BCPs or birth control pills are there? You've got a combination pill, and what that means is a combination of the different steroids, the estrogen and the progestin. And you've got a progestin-only pill that doesn't have any estrogen in it. And pills are classified on the amount of estrogen in them. And they're called a high dose or a low dose. And it ranges between less than 35 micrograms of estrogen and more than 35 micrograms of estrogen. Now, some people use the pill not just as a contraceptive, but if they're a super athlete and they've stopped having periods, or if they have an eating disorder and they've lost so much weight they also have stopped having periods, then it's probably a good idea to replace the hormones that they're not making, the estrogen and the progestin or progesterone. And if there's somebody with anemia and they have just heavy periods, pills would be good to decrease the amount of bleeding. And if they have a cyst that gets big and causes some discomfort for them, this would stop the cyst from even forming. And if they just get emotionally upset because they've had such terrible times with having periods, that's another reason they may want to go on the pill. If they have a family history of cancer of the ovary, pills have been shown over years to decrease the incidence of ovarian cancer. And also, it's been shown to decrease the risk for cancer of the endometrium. So if you've got family histories of people who, siblings or parents or moms who have had either ovarian or endometrial cancer, it would be good to consider using the pill. Well, it's been suggested that how to take the pill has been unnecessarily complicated. And that may be true, yet it was done the way it was done to make it acceptable in the 1960s and to make it appear as normal. Well, there's no need to stop the pill to have a period. I think people thought that if you didn't have a period, then you'd have all of this blood in your uterus and it would swell up to be the size of a basketball. And so you need to have a period. Well, that's just not true because you don't grow much lining in the uterus and you don't need to have it got rid of if you are taking the pill. Well, when does protection? Well, when does protection begin? It begins after 7 consecutive pills have been taken, and it continues until one's discontinued. And the reason I think people were advised about it that way was because if you miss the one after the 7th, that'll be day 8 of the cycle, and you could ovulate. So they just say protection begins after 7 consecutive pills have been taken and continues until one is discontinued. Well, it is important not to miss a pill. If there's ever a question about am I protected, use additional contraception until you've taken 7 consecutive pills. When to start the pill doesn't really seem to matter if you don't have any reasons you shouldn't take the pill, called contraindications, and you can start taking it anytime. You take it the day you get it. Then you got to wait 7 days to take the 7 consecutive pills. Well, what kind of pills are there? There are progestin-only pills that have no estrogen, and they're lowest estrogen pills, some with 20 micrograms of estrogen, and all of the 25, 30, and 35 microgram pills use ethinyl estradiol. Highest dose estrogens use mestranol, and that's converted to ethinyl estradiol, and 50 micrograms of mestranol is equivalent to 35 micrograms of ethinyl estradiol. And then there are pills to be taken every day of the year. And they have 90 micrograms of progestin and 20 of ethinyl estradiol. And the one you take every day of the year, that's just one per day. This is a generic, it's Librel. And if you don't want to have a period, it doesn't cause any problem not to have one, just don't stop your pill. Or if you want to arrange when to have a period, you can do that. You stop your pill, but wait no more than 7 days, restart it. And I don't know if they've done studies to see if there's an increased pregnancy rate in this particular pill if you don't wait 7 days. Well, withdrawal bleeding is also referred to as breakthrough bleeding, and it can be predictable as well as unpredictable. Estrogen progestin hormones cause growth of the endometrium. When the hormonal level is decreased, there can be something called withdrawal bleeding. Hormonal levels fluctuate, and that makes it difficult to know why and when bleeding will occur sometimes. Surprise bleeding is always unwelcome. The pill is the most popular contraceptive, and it's been thought that the pill-free interval may have been responsible for some pregnancies by allowing ovulation in some people. Well, when to start the pill, it doesn't matter if you don't have any contraindications. When's protection begin? After 7 consecutive pills. When does protection end? Assume when a daily pill is missed. Now this just shows that some things work better than others. And this is the popularity of contraceptives. And what you can see, number 1 is the pill. Number 2 is female sterilization or tubal ligations. And number 3 is the condom. Two kinds of contraceptives, LARCs, and that's a long-acting reversible contraceptive, and a SARC, and that's a short-acting one. And with the long-acting ones, you get it and forget it. And the ones that are in that category are IUDs and implants. The other ones, you have to remember to take or get an injection or new pill patches or rings. Some of the reasons that people use the pill other than contraception is because of terrible periods, and the pill makes them much better. And I think we already talked about most of the reasons here. If somebody has endometriosis, and usually you get that when you get older, but if you have endometriosis, the pill's going to be a good thing, because endometriosis is a condition where you've got parts of the lining of the uterus growing outside the uterus. And if it's growing, that can lead to bleeding and pain. And if you take the pill, you'll decrease the growth of those patches of endometrium growing elsewhere. And that'll be very helpful. So how do you increase how well the pill works? Well, the ones you take every day really eliminate a pill-free interval for which some users may have been the cause of their ovulation and subsequent pregnancy. It eliminates periods for many and has high satisfaction with patients. Quick start the day seen if no contraindications. How to manage breakthrough bleeding? Sometimes the NSAIDs, something like Motrin, can be helpful. Well, if somebody is talking to you about contraception, they should eliminate their biases. They should determine what's you want by listening, and success is associated with your being satisfied. So thanks for your attention. That's it for this particular one on birth control pills.